2, 1. We're live.
All right.
Take it away.
Well, great, thanks. Well, thank you for the opportunity to present to you today and talk with you about HIV prevention in special populations. My name is Nick Van Wagoner, and I am an associate professor at the University of Alabama at Birmingham, where I have a sexual health clinic where I do work with special populations who are at risk for HIV as well as other sexually transmitted infections. And it's a pleasure to be here to be able to share this with you today. Now, let's see if it will move forward. There we go. So I don't have any disclosures. Well, I do. I have one disclosure for Simply Speaking, where I do speak occasionally on HIV management. It's an expert educator CME lecture series. And I also want to thank David Wohl from UNC for sharing his slides with us, with me, and some of his slides are included in the presentation today. So the objectives for this particular presentation are three. The first is that I want to identify people at greatest risk for HIV. And really what we're talking about is special populations when we identify these groups. A point that I'll make now, and again in the lecture, is how important it is to consider the individual, because there are layers of variables that may influence the risk for HIV in an individual, and the only way we're going to know that is if we ask our patients. After we talk about that, our focus will be on understanding the role of pre-exposure prophylaxis in HIV prevention, and then we'll discuss opportunities to improve pre-exposure prophylaxis uptake in our patients. So, question for everyone: who is at risk for HIV? And another question is what puts people at risk for HIV? Well, we know that there are a lot of variables, but for what I'm going to focus on for the next few minutes is four specific factors: behavior, age, race, ethnicity, and also location. Where does a person live? What is the prevalence of HIV in that particular area? And how does that influence their risk of acquiring or HIV? So if we look at HIV and behavior first, and we use the data to guide this discussion, in 2017, we know that there were over 38,000 new HIV diagnoses in the U.S., and 66% of those were among gay and bisexual men. So men who have sex with men account for most of the new HIV infections in the United States. This was followed by heterosexual individuals who count for almost a quarter of new infections, followed by individuals who inject drugs. So we know that sexual behavior does increase risk of HIV. If we think for a second about age, what we have observed is that the younger individuals have a higher incidence of HIV. What you're looking at here is estimated HIV incidence data over time from 2008 to 2014. And if you focus on the orange line, what you are going to see is that there has been an increase in the incidence among individuals who are aged 25 to 34, whereas in most of the other groups there has been either a flatness to the line or there has been maybe a slight decline. Now that's data up to 2014. If we look in 2017, what you're going to see is similar data, and that is if you look at the red bar first, individuals aged 25 to 34 account for the most cases of new HIV. This is followed by those who are 13 to 24. As individuals get older, there still is risk, but you can see a decline in, or I should say, new incidence of HIV. So really, those who are 13 to 34 appear to or account for the majority of new HIV infections. If we think about location and risk or the incidence of HIV in different locations, what we know is that most new HIV infections are occurring in the Southeast. In fact, if we compare the Southeast to other parts of the country, the Southeast, and that means from Texas over to North Carolina, accounts for over half of new HIV infections. If we break it down even a little bit further and we look at even more focused locations, for example, Washington, D.C., you can see, and now we're looking at prevalence, that 2.5% of people in Washington, D.C. have HIV. And if we then overlay other factors such as race, ethnicity, you can see that the rates can become even higher. For example, Washington, D.C., among black men, almost 6% are infected with HIV. This is comparative or close to the rates that we do see in some African countries with high rates of HIV. If we now look a little further at race ethnicity, what you can see is that black men who have sex with other men have the highest or most affected by HIV, with almost 10,000 new infections in 2017. This is followed by Hispanic Latino men who have sex with men, then by Caucasian or white men who have sex with men. In women, there is a high prevalence of HIV among black women, and you can see that the lowest prevalence is among white women. So what we're saying here is that not only is location, age important in risk for HIV, but also HIV is a very important example of a health disparity where we find higher rates among certain populations based upon race ethnicity. Another way to look at this, if we overlay a couple of the different variables now, is pretty profound in my opinion. So if we look at the lifetime risk for HIV diagnosis by race ethnicity, okay, if we look among African American men, what we see is the risk is 1 in 20. Okay. If we look at African American women, we see 1 in 48. And again, we can look at the other groups in the study as well. Now, if we overlay sexual behavior on this, what we're going to see is this. If we look at total MSM, the risk for HIV lifetime risk is 1 in 6. But if you're an African American man who has sex with men, your lifetime risk of acquiring HIV is 1 in 2. That's profound. If we look at Hispanic MSM, the risk is also incredibly high with 1 in 4. And so as we see our patients, we need to take all of these variables into account to understand risk and also to be able to educate our patients and answer their specific questions and provide protection, as we will talk about a little bit later on when we talk about PrEP. Before we do that, I want to take a moment to talk about HIV and transgender people. Transgender people have a very high rates of HIV when compared to the rest of the U.S. population. This is data from 2009 to 2014. And in this particular analysis, there were 23,000, a little over 23,000 transgender people who received an HIV diagnosis. Of these, 84% were transgender women, 15% were transgender men. And similar to the data I showed you before about where in the country we are seeing the highest prevalence or the highest incidence of HIV, about half of new incident cases among transgender people was in the southeastern United States. What this translates to is that about 22 to 28% of transgender women are living with HIV. And if we then overlay race ethnicity onto that, what we have observed or what is reported is that 56% of African American transgender women are living with HIV. Incredibly high prevalence among transgender people. And so coming back to the question, when the person is sitting in front of you and you're trying to understand their risk, certainly we want to take these things into consideration. Behavior, age, where does a person live, what is the prevalence of HIV in that location, as well as a person's race, ethnicity. But we don't want to forget that people are individuals, and in order to really understand their risk, we need to ask. We need to communicate effectively with people and talk with them about their potential risk for HIV. All right, so we've talked a little bit about identifying people at greatest risk or special populations and the incidence and the prevalence of HIV in special populations. Now I want to turn our attention to understanding the role of pre-exposure prophylaxis in HIV prevention. Before we get to that, though, I do want to remind you that this isn't the only tool that we have to prevent HIV. Certainly condoms are effective prevention, as well as education. For people who inject IV drugs, needle and syringe exchange programs are helpful in reducing HIV transmission. We also know, and as discussed in other parts of this particular conference, that STIs and the presence of an STI increases a risk of getting HIV. So we want to do screening for STIs and treatment. Certainly HIV testing. We know when people know their status, that means that if a person is positive, then they can become engaged in care for their HIV. And we know that once their viral load, a person's viral load is undetectable, that they cannot transmit HIV. And I know that there are several others on here, but I'll call your attention to the last one, and that is pre-exposure prophylaxis. So again, before we get to that, one last point is that there is a national push and agenda to try and end the HIV epidemic, and the goal is to reduce by 75% new HIV infections in the next 5 years, and to reduce the infection rate by 90% in 10 years. And this is going to require a lot of different facets. For example, we need to do a better job with diagnosing HIV, a better job with treating the infection to effectively suppress the virus and reduce transmission to others, as well as protecting the individual and keeping them healthy. We also, for those people who are at risk, again, what we're talking about, we want to protect people from acquiring HIV. And so this is a multi-pronged approach. But what can, and there are several places within the United States where the focus is great on doing this. And so these are areas you can see with the dots of cities, parts of the country with the highest burden of HIV where targeted campaigns are ongoing. The states that are in blue are actually states with high rates of rural HIV infection that are being targeted to try and address the epidemics in these particular locations. So what can we do, and what are the tools that we have to prevent HIV and protect our patients? Well, pre-exposure prophylaxis. Pre meaning before exposure is contact with HIV, and prophylaxis is treatment to prevent infection. And the FDA-approved medication that we have for this is a fixed-dosed pill, so it's one pill with two medications. The first medication is emtricitabine, and the second medication is tenofovir. If we look at how effective this particular medication is in initial studies, it really does work. When taken consistently, and this medication is prescribed for individuals to take on a daily basis. So for individuals who take PrEP on a daily basis, it does reduce the risk of HIV infection by 90 to 100%. Now, these studies have been done in cisgender men who have sex with men, heterosexual men and women, as well as transgender women. Further studies have demonstrated that PrEP is effective among persons who inject drugs and have reduced HIV infections by 84%. So it is a very effective tool in reducing HIV. Now, these were studies that were randomized. They were controlled studies. They were looking at the benefits and the effects in a very controlled environment. So what do we know about real-world use of these medications? Well, this is a study called the PROUD study, and in this particular study, they took men who had sex with men who were coming into STD clinics in London. And what they did is they randomized individuals to one of two groups. They said, okay, half of the people in this study are going to start on PrEP now, okay, and start taking it now. The other half, we're going to defer PrEP for a year. And what they observed is that those individuals who immediately started on PrEP had a much reduced, in fact, an 86% reduction in new HIV infections. So 3 in the immediate versus 19 cases in the deferred. What this means is that we would need to treat 13 people with PrEP in order to prevent 1 new HIV infection. It's a pretty impressive reduction in new HIV infections. And again, this is a real-world study. The medication was offered to those individuals. They were able to take it as a part of their of their regular life. Now, if you say, well, that's still a little too controlled, let's look at what's happened in the real world, looking at data from Kaiser Permanente. Kaiser Permanente actually reported this data from its period of July 2012 to February 2015. And during that period of time in their clinics, they actually made 1,045 referrals of individuals who would benefit from PrEP. Of that group, 80% of patients actually were evaluated in person for PrEP or made it to that visit to get PrEP. And of that 80%, 82% or 62% of those who were originally referred were started on PrEP. And they continued on PrEP as a part of their routine clinical care. At the time of when this study was done, they were able to they had almost 400 person years of follow-up. And what they observed was this. Of the 388 person years, there were 187 new STIs, which means that the people who were taking PrEP were engaging in sexual behavior that put them at risk for STIs, but none of those individuals acquired HIV. This suggests to us that if taken every day, that PrEP is very good at reducing the risk for HIV and can reduce new infections. Now, what is the impact of PrEP? Well, it's difficult to say because, again, there are a lot of different programs in place that are trying to address the HIV epidemic. If we look from 2008 up to 2014, we have seen a decline in HIV incidence, okay? And what you're looking at here is HIV incidence in the thousands, okay? And so what we have seen is over time there has been a decline. PrEP was introduced during this time frame, and you can see that there has been some continued decrease in new HIV infections. If we look at this a little bit different way, because we're looking at this and we're saying that, if I go back one slide, that the reductions have been relatively modest. But I think this helps to put it into perspective, and that annual infections have declined by about 8% from 2010 to 2015. And this is data, you can see the reference that is listed there. What does that mean? Well, this means that an estimated 15,800 cases of HIV were averted, and this prevented $7.6 billion in spending for lifetime HIV care, or reduced the cost of care by that much. So even this is a profound improvement and a benefit to thousands of individuals. And hopefully we'll continue to see the decline. So what we know is that PrEP, when taken, reduces new HIV infections. So the question is who is PrEP right for? Well, there are various different tools, and I'll give you some resources in a moment, that can identify people who may benefit from PrEP. And these include people who have anal sex without condoms, individuals who have a history of bacterial STIs, individuals who infrequently use condoms with partners of unknown HIV status, people who have sex with HIV-infected person or persons, and of course, individuals who share injection or drug preparation equipment. These are individuals who would benefit from PrEP. Taking data from various national surveys, this particular study that was reported in MMWR in 2015 said that if we look at risk factors, we can identify about 1.2 million people in the United States who would benefit from taking PrEP. And what I want to point out on this slide is similar to what we discussed right at the beginning, that sexual behavior does correlate with risk, and men who have sex with men are at the highest group. What this is saying is that even among men who have sex with men, only about 25% of those individuals would be at a place in their life where they would benefit from PrEP. Okay? What it's also saying is that we look among heterosexual people, the percent who would benefit is 0.4%. But when we look at the prevalence of heterosexual individuals versus people, men who have sex with men, even though it's only 4% of the heterosexual population, that equates out to about 624,000 people, heterosexual people who would benefit. So when I'm seeing a client in the clinic, it's important, coming back to individualized understanding the individual in front of us and understanding their specific risk and potential benefit from PrEP. So how are we doing with that? Well, I'll come back to that in just a second, because I think that that's an important question to ask. If you're someone who is able to provide PrEP and interested in providing it, there are recommendations for the provision of this medication, and that's through the CDC, the WHO, American OBGYN societies, as well as other societies who provide guidelines for the treatment of HIV. All of them provide criteria for determining people who would benefit from pre-exposure prophylaxis, as well as guidelines as to how to prescribe the medication. And so the references are listed here for those of you who are interested in learning more about the specifics of prescribing this medication. Even though we have a medication that works, it only works if individuals have access to the medication and they adhere to taking the medication in a way that will provide them with protection. We know that there are a lot of challenges. Cost of PrEP is one that has come up. There may be policies related to it. There may be access. Patients may not know where to go. There may not be clinics available. They may face stigma and be concerned about coming into a medical system or to their provider and asking them for this medication out of fear of it may out them, or they may worry that their providers will not want to provide it to them. So there are a lot of different issues that can interfere with the prescription of PrEP. And we do see this in some populations. What we are observing is that although PrEP will benefit everyone who takes it, we are seeing that higher utilization is occurring among white individuals. Now, I'm glad that there are people that are taking PrEP, but if you go back and think about the risk factors that we talked about and the lifetime risk for HIV, certainly African American MSM have the highest risk, and unfortunately to date they have lower uptake of PrEP. So there are real opportunities, especially for us in the southern United States where the incidence rates are so high and we have more diversity than other parts of the country, and an opportunity to provide this medication to the clients that we are seeing. We know that there is also opportunity because we're lagging behind other parts of the country in PrEP delivery. In fact, even though we account for 52% of new infections, the southeastern United States only accounts for about 30% of all PrEP users. So room for growth and for us to engage our clients in conversations about PrEP and prescribe PrEP. One of the challenges with PrEP is sometimes even when it gets started, people will stop taking it for various reasons. It may be that their perceived risk changes at different times in their lives, or they may not understand risk. It may be access. It may be cost. Again, it may out them to other people. So there are a lot of different reasons why individuals might discontinue PrEP. And so for the provider, I think it's an ongoing conversation of understanding not only how a person is doing with potentially side effects of a medication, but trying to understand what are the barriers for that individual and trying to work through those barriers in order to continue PrEP for those who need it. There is opportunity for us with our patients when we're sitting across from them to help us overcome some of the challenges to providing PrEP. And I think that also there are other ways. So certainly policy, working to improve access, maybe things that we don't necessarily deal with every day, but hopefully changes will come at this level as well to make PrEP prescribing easier for us. So what is in our control, though? What can we do to prescribe PrEP? Certainly, I think we need to know our patients. Again, I said I would come back to this a few times, and I have. That is having those important conversations about sexual health, risk for HIV, and opportunities to protect the patient against HIV. We also want to share PrEP knowledge. You know, it's interesting. When I'm in clinic, one of the questions I have, if in the sexual health conversation, when I think that a person may benefit, it's a simple question. Hey, tell me what you know about PrEP. And that starts the conversation. It may be that the person isn't ready to start that day, but you open up the conversation and can let them know that you are a resource for it if they decide that they want to start on PrEP. I think that knowing your patient is coming back to this. We got to ask a sexual history, and we need to know history of injection drug use as well. Sometimes can be challenging questions to ask, but certainly important questions to ask. When we talk about sharing our PrEP knowledge, sometimes I get intimidated and feel like I need to know a lot about it, when in fact we really don't need to know a ton about it. And this is a resource from whatisprep.org. You can find similar information at the various sites that are listed on this page, everything from the AIDS.gov to the CDC, that can provide information about frequently asked questions for patients. So from everything from what is PrEP to is PrEP right for you can be very helpful tools and resources for patients who want to learn more about PrEP. And the reason this is a study actually looking at individuals and their desire to learn more about PrEP and how many had known about PrEP. So this was a study that was in Chicago among women, and it was a survey of 370 HIV-negative women who were coming into either a sexually transmitted infections clinic or an ER in Chicago. And you can see the sexual behavior there, 93% inconsistent condom use. Interestingly, 90% perceived their HIV risk to be low or to be non-existent. only 30% of individuals had heard about PrEP, and about 29% of individuals in the study said, hey, yeah, I would consider PrEP. So an opportunity is, I think, ours as frontline providers to bring up the conversation and share information with our patients. The final thing I will say is it's important to know local resources related to PrEP delivery. Often it's the question of, well, where do I send somebody? And so in North Carolina, I've been really impressed by the resources that are available. If you look at the website for the North Carolina AIDS Training and Education Center, they have outstanding information. They have consumer resources there as well as provider resources there and a list of providers. And this is an example of a map that lists where PrEP providers are in the community. There is also a table which gives you contact information for clinics. It talks about what types of insurance they take, really it's an impressive number of clinics that do offer PrEP in your area. So it may be that you don't provide PrEP, but you can provide a referral to a location where a patient can acquire PrEP and benefit from PrEP. All right, so I'm going to go ahead and stop there and just remind you that the objectives of this and sort of a few closing comments. So certainly we know that there are individuals at greater risk of HIV than others. People we consider special populations, and although it's important to use this data, I think it's important to recognize or think about the individual that is in front of us and talk to them specifically about their sexual health and their risk for HIV. We've talked a little bit about pre-exposure prophylaxis. It's a one pill once a day regimen that does protect people against the acquisition of HIV. And although there's a lot of room and work to do to get everyone access to pre-exposure prophylaxis, I think that we as frontline providers can share information in such a way and provide resources to our patients, even if we're not able to prescribe PrEP, that will help them potentially get the medication if it is relevant to them and their needs. And so if we think now for just a moment about the future of PrEP, right now we have a one pill once a day option. But I think that there are going to be other options in the future. It may be that there are injections, there are vaginal rings, there are other resources to our patients besides taking a pill every day that will be able to protect them against HIV. And what you're looking at is the pipeline for the development of different types of pre-exposure prophylaxis delivery. And the final thing that I would say is that, our goal is to protect our patients from infections and to keep them healthy. And so I think that PrEP is really not just an important tool for doing that, but it is also a matter of social justice because we want to prevent infections among all people. It really is a matter of equity and is good medicine as well as good public health. So at that point, I'm going to go ahead and stop, and I'm happy to answer any questions if there are any questions.
Dr. Van Wager, can you hear me? On your slide with transgender patients, you said 23,500, but the slide said 2,351. I just wanted you to clarify.
Yeah, thank you. You are correct. It is. I misspoke. It is the 2,000. It's not 23,000. Thank you for that.
You're welcome. So I think we gave you a list of questions, and then I'm going to pull up some more while you answer those.
Okay, so a couple of questions that I have is what are the side effects of PrEP? So really, PrEP can cause side effects, but they're relatively rare. Most of what we see are things like nausea, and it generally occurs right after a person begins taking the medications, and that subsides over time, usually within the first week, 2 weeks. If a person does have some nausea, it it goes away. Other than that, there really have been no serious side effects observed among patients. One of the things that is done, one of the medication in pre-exposure prophylaxis is tenofovir, and so we do follow patients' kidney function. There have been rare cases where it has caused increases in creatinine, but again, this is quite a rare event, and for the prescriber of PrEP, they are following creatinine in that particular case. All right, so another question has to do with whether there are any challenges, contraindications to providing PrEP in transgender people, and the answer is no. There is no interactions with hormone-affirming therapy, whether that is for a trans man or a trans woman. There really isn't any contraindication, and so I definitely would recommend, based upon your sexual health history with the patient, prescribing it if you find out that there would be a benefit for protection in that particular case. Another question is how long does it take PrEP to become effective? Well, that's a really, really important question. And what the data is telling us is that is a little bit dependent upon the type of sex that a person is having and the area that you want to be protected. So if what we know is that PrEP reaches sort of its maximum protection from HIV for receptive anal sex about 7 days after daily use. Okay, so if a person is going to engage in receptive anal sex, they should take it for at least 7 days before it's protected. Now, it's different for receptive vaginal sex and for injection drug users. It's that the PrEP really reaches its maximum protection at about 20 days of daily use. And so what I recommend to my patients is just that. 7 days for receptive anal sex, and anywhere from 20 days to about a month for protection from vaginal sex and for IV drug use. Another question that I have has to do with, do you have to stay on PrEP for the rest of your life once you start it? And the answer to that is no. And it's a really important point when prescribing PrEP is that the provider should assess the patient's risk. It may be that somebody is at a point in their life where they are having more casual partners. It may be at a different time that they are abstinent from sex. And so what you want to do is base their utilization of PrEP upon their risk. I've had patients who have taken it for a year or two and then have said, I'm at a place in my life where I don't plan to have sex for an extended period of time. I plan to come off of it. I've had other people who have said, I'm in a committed relationship now. We've both been tested. We're negative. We have decided not to have any casual partners, and so we want to come off of PrEP. Again, you want to talk with the patient specifically about the risks and benefits of that, but these would be reasons why. I've had patients who have been in long-term relationships for years, and that relationship has ended, and they did not consider themselves while in those relationships in need of PrEP. However, as that relationship ended, they have asked to go on PrEP. So it's going to be something that can be started. It can be stopped as well. But whenever it's restarted, it's important to remind them of the length of time that it takes for that to become effective. Okay. All right. So those are the questions I have so far. So any other questions?
I think we're just going to end with that, and we appreciate your great presentation and hope that you can update us at the 2020 North Carolina STD conference.
All right. Well, I appreciate it very much.
Thank you.